thank Vishweshwaran for inviting me for this program. I mean, the trio of Vishweshwaran, Hari was sitting somewhere back out there, and Nagarjun have done a fantastic job in interventions over the last few years, and they've brought IP really into the limelight. I'd like to keep this session interactive because it's very, very boring to have a very didactic lecture. I know we do have the hands-on training session a little later in the day, but I'll appreciate people who want to interrupt or who want to ask questions even through the presentation or maybe in the end, whichever it is. So that's okay with me. So Vishwesh has actually tasked me with speaking about rigid bronchoscopy, and I'm going to be talking over the next 20 minutes on instruments. I'm going to be talking on accessories and on intubation. So I'm Dr. Kedar. I come from Narayan Area. This is a big hospital on the outskirts of Bangalore. We cater to a lot of heart patients, but we are also a multi-speciality hospital. During my entire presentation, I've seen often in conferences people take slides. That's my email ID for you guys. Anyone is needs my presentation, please write to me. I'm quite happy to share all the slides with you. So there's no need for you to take photographs. All the material on my presentation is for teaching and training, so I'm quite happy to share it with each one of you. So let me start by what Robert Kennedy said, and this is very, very true in 2022. Few will have the greatness to bend history itself, but each of us can work to change a small portion of events, and it is the total of all these acts that will be written the history of this generation. So what we're witnessing today is what started as a journey in 1980 when Jean-Francois Dumon put the first stent, and that was in some ways the rebirth of interventional pulmonology. And each of the people who came after 1980 contributed in very, very small, minute ways, and in fact even before 1980. But why today we are here to discuss interventional pulmonology is the large leaps that have happened after 1980 when the first silicon stent was inserted. I invite each one of you who are teachers and trainers both here to read this article which was published in SRCCM, the Seminars in Respiratory and Critical Care Medicine. This is probably the landmark article which probably will explain everything about rigid bronchoscopy that you need to know. So this is something that is there, you can actually download it, and it's probably one of the best articles on rigid bronchoscopy that you guys will be reading. So what's the agenda for today? I'm going to be talking about equipment setup. I will talk about the bare essentials. I'll tell you what different scopes are available, and each of these different companies today are there in the workshop. We'll talk about patient positioning, and we'll take you through the intubation step by step during the workshop, but I'll briefly discuss it here as well. I'm running my presentation through these headings. We'll first introduce the topic to you. I'm going to talk a little bit about the history. I'll talk about indications for rigid bronchoscopy, the instruments, induction, the intubation and the insertion technique, and we'll look at a bit of interventions, but very, very little, but I'm sure the speakers after me are going to cover a lot more after that. So, introducing this topic, we all have heard of these two gentlemen, Gustav Killian and Chevalier Jackson, and that's where our story started, and this was way back a century ago in 1890, when the first foreign body was actually removed. Chevalier Jackson then built up his own instrument, a rigid bronchoscope with distal illumination, and then came Hopkins, who improved upon the optics and built the telescope, and then it came to Storrs, and Storrs has a huge presence now with their rigid bronchoscopes, and they are actually building a lot of scopes. Then comes the birth of interventional pulmonology, or the rebirth in some ways. This was after Dr Ikeda actually introduced the flexible bronchoscope, and that is where rigid skills went out of the window for a very, very long time. And when the first stent was inserted, that is when we started rediscovering that having rigid skill in pulmonology is extremely important. In Europe and US, more so in Europe, the rigid skills continued to be there over the years despite the flexible bronchoscope being available, and that's really what has kept us going to this day. This is Gustav Killian, and this is the poke bone that he actually removed, and I'm sure each one of you has seen. He's known as the father of modern bronchoscopy. But I'll highlight you this very interesting book by Mary Capello, which is on your left. This is a book called Swallow. In Swallow, Mary Capello speaks very interestingly and has done a lot of research about Chevalier Jackson, whom we know as the father of American esophagology. And there's an entire museum of all the objects he has removed, during his lifetime in a place called Pennsylvania, where there's the Mata Museum. So if any one of you had the chance to go to Pennsylvania, please visit the Mata Museum. You will probably see every single of the 2000 plus objects that he has removed and catalogued. There are beautiful stories about how these patients came. He built his own instruments. Every single object, whether it is a pin, a button, or any kind of object that was there, that was removed by him, has been displayed, catalogued very beautifully. And this book actually tells and takes you through some of the stories that Chevalier Jackson came across, because removing foreign bodies is in itself always a story. In fact, there are stories of how he was threatened to return some of these objects, which he kind of resisted, and that made him a big people resisted it, and still he decided that he wanted to keep those objects. So these are the kind of objects that have been removed. And interestingly, it's not just the objects that he removed. He in fact built his own instruments, for removing these things, because he did it in his garage. So that's really what keeps him apart. He was not just a guy who removed instruments. He was an innovator, making newer instruments, experimenting and improving the science every single time. So these are some of the instruments he designed in his garage over a period of time. And that's Chevalier Jackson for you, with each one of his objects and drawers catalogued and beautifully kept. A year ago we lost this gentleman. Many of you who've kept in touch with pulmonology probably are aware of it. His name is Dr Francis Dumon. In 1980 was the first publication that was a short note which had come in a French journal, after which Chest published it, and that basically was the birth of interventional pulmonology, and that spoke about how he inserted a silicone stent. So let's get now from history to the indications. Like I've already spoken a lot about in the last few slides: foreign body removal, removal of clots, retrieving airway obstructions from tumor or stenosis. It could be both benign or it could be malignant. Endoluminal therapies, when you want to use it hot, cold, and the new entity which is getting rediscovered again, which is neither hot nor cold. Stents, transbronchial cryobiopsy. The area of ILD has hugely advanced, and that's where now we are rediscovering why it is important, because bleeding is a major issue out there, and for achieving hemostasis we require rigid bronchoscopic control, and of course the good old hemoptysis management, where you can try and see if you can isolate the lung, ventilate the lung, and keep the patient going. There are contraindications: uncontrolled coagulopathy, cervical spine related issues, extreme ventilatory and oxygen demands, and tracheal obstruction with a novice operator. But it is important for all of you to understand that the kind of situations we almost always deal when we want to do rigid bronchoscopy, especially the central airway obstructions, are always a life and death situation. So some of these are not strictly contraindications. I would call them in some ways relative contraindications, because your intervention can probably improve their life, because you're going to palliate the symptoms by inserting a stent or controlling the hemoptysis that the patient may be having. This is the important area which Vishweshwaran wants me to cover, and we're going to talk about scopes. We're going to talk about tracheoscope and bronchoscope. We're going to talk about optics. We're going to talk about the accessories that exist, and also the ventilation. So what basically is a rigid bronchoscope? It's nothing but a straight hollow metallic tube, and it has various lengths and diameters. Usually 33 to 43 is the length, but there are some instruments Dodds is making of 20 centimeters as well, where you just want to be inside the trachea below the vocal cord. The diameters vary from 5 to 16. The lesser ones are used more from the perspective of pediatrics, while sorry. Yeah. So the lesser ones will be used in pediatrics, while the ones with greater diameters are used in adults. The wall thickness of each of these tubes is between 2 to 3 millimeters. Important thing is the distal end is beveled, and that's what actually helps you in lifting the epiglottis during intubation, when you want to do the coring in the trachea and so on and so forth. While the proximal end is made in a way which will attach the maximum number of instruments and gives you a lot more ergonomic independence to maneuver many of the instruments that you are likely to use during rigid procedures. This is a very simple diagram showing you two rigid bronchoscopes, or rather rigid tubes. The one on top, if you notice very closely, is longer, it is thinner, and it also has got vents. The one which is below is of course shorter than the one on the top. It does not have vents, and of course is much more thicker when compared to the one on the top. So in very simple terms, what is the tube that can go inside, which is more thicker, which does not require to ventilate the other lung? is just the tracheoscope. So many people call even that a bronchoscope. So what you see below is the tracheoscope, what you see on the top is the rigid bronchoscope. So that's really the difference. The vents are there basically to ventilate the contralateral lung in case you have entered one of the main bronchi for doing the procedure. So that's the difference. So these are basically rigid tracheoscopes, and you can see that they come in various diameters. And these are the rigid bronchoscopes that come in. There are various sizes available depending upon what you want. The accessories are required for closing many of the ends that you really have in these instruments, and that helps in preventing both the leak and keeping the procedure neat. And when a rigid bronchoscope has a Hopkins inside it with all the accessories attached, this is really how it looks. Basically, this is what is the instrument that is your instrument of choice when you want to do rigid bronchoscopy, or how it ends up looking at the end of it. So what is important to understand is over a period of time from 1980, many innovators and many people who have been doing rigid bronchoscopy have started giving ideas to companies, and it has led to many newer innovations. And a simple one of those innovations is this called the telescope guide sheet. So in the olden days, the Hopkins used to be held directly in the hand. Now you have a telescope guide sheet where it just doesn't slip while doing bronchoscopy. So it's not a must-have accessory, but if you have it, it's great luxury. And then over a period of time of having both post-intubation tracheal stenosis and post-tracheostomy stenosis, we found that in Netherlands there was this place called Groningen where they invented the tracheal stenosis dilators. So the one above is the pediatrics one, the one below is the adult one. So it's really no different. All that it does is what you do with your balloon bronchoplasty. So all you have to do is give your cautery cuts and either use this rigid bronchoscope to dilate up front, or you can do the same thing with the balloon. So either ways it's just the same, but it's all about the luxury of having an extra instrument and if you can afford it. There's only one paper till date that I have come across on the both telescope guide sheet and the use of the Groningen tracheal stenosis dilator, and this is from an Indian Ajmal from PGI, who is now in SDPGI, and he basically published a paper on how easy it is to do these dilatations using this instrument. Like I said, the older instruments had a head attached, and now they don't want to keep removing every single time the entire assembly and reinserting them. We'll deal with all of these during the workshop, but all I'm trying to demonstrate here is the ergonomy that has changed the landscape of interventional pulmonology and rigid bronchoscopy. So instead of every time extubating the patient and going in with a new tube, you have a head with all the accessories attached. So all the accessories get attached to the proximal end of the head, while the tubes just get changed with a click. So that's really what has changed in the rigid bronchoscopes from the era between 1980 and today. So this is the new Datau Novatech rigid bronchoscope. Datau is likely to be giving you a talk. He is the prodigy of Jean-Francois Dumont, who's going to be talking tomorrow. And all he's done is, ergonomized the F.R. Dumont scope, which was so widely used in Marseille, where he is the lead interventional pulmonologist. This is the original F.R. Dumont rigid bronchoscope with all its accessories. It's very, very similar to the Datau scope that is now available, except that it's a little more ergonomized in few aspects. This is an important slide for many of you to understand, and I think each one of you, when you come to the workstations, have to spend a little time to understand. So what you need to understand is what happens at the proximal end. And there are multiple insertion ports, and these insertion ports are the ones which are very, very important. So all you require to understand, many people tend to get confused. So the simple way to keep this in memory is by understanding what are the requirements that your patient has during a rigid bronchoscope. A very simple thing is, as an endoscopist, you need visual feedback, and that's what the Hopkins does, which goes at the proximal end of the scope. So anything which requires a visual feedback requires a light source. So the light source gets attached to the Hopkins. So that's basically what happens. So you have the Hopkins here, you have a light adapter to it. This is your rigid bronchoscope. So there is one port for ventilation and another port where you can put in your prism. And there are multiple accessories which you can attach at this end, which can be your suction, which can be your laser port, or any other device that you want to have it during the entire procedure. And you have the light prism which goes up here, the ventilation tubing that goes here, and the rubber nipple and suction cover going here, which can serve as your jet ventilator's insertion port. Let's get to the next part of instrumentation, which is visuals and monitors. So you need an optical telescope. Usually what you use is a 0 degree, and the thinner the better, and the thinner is also because you want to be able to insert stents, and you need to have as much space to do whatever you want to do apart from having the stent inserted at the end of the procedure. So you need a light source and a camera system, a flexible bronchoscope. That's usually because you require to use your rigid bronchoscope in often situations as a conduit, and of course you need video monitors. These are just photographs of Harold Hopkins and of Karl Storz, who is a German instrument maker who's revolutionized the entire rigid bronchoscopy. So many people think buying the rigid bronchoscope is the end of the journey, and in fact that just is the beginning, because it's not just buying the rigid scope and then illuminating feedback mechanisms that finish your set. You require optical forceps and graspers, you require suction tubing, you require balloons and dilators, you require a ton applicator if you want to insert stents. And alternatively, if you have a mixed or an endoluminal problem, you would require hot or cold therapies to intervene into it, which could either be in the form of electrocautery, it could be in the form of laser, or it could be in the form of ATC. And of course, if you have cold therapies, you have cryoprobes, and the new generation which you're likely to see in the workshop is the 1.1 mm and the 1.7 mm. Of course, there is a lot of talk about other things about cryoneedle spray cryotherapy, though they are not available in India. So, just to give you an idea, which you will also be seeing during the workshop, is what you're seeing the instrument on top. You can't insert an optic, so that's basically a non-optical instrument. And here you have a channel for inserting your optical instrument, which is the Hopkins, so that's called as an optical instrument. So this basic thing that you have to remember. And these days, even the accessories are getting very posh. So you have the Roteps forceps coming in with different accessories, and that's again just increases your ergonomy and your workspace during the procedure. The ends of these instruments are what are very important. So you have a biopsy forceps, you have scissors, you have crocodile, you have a stent removing forceps. You also have instruments which will help you reverse grasp and pull out things in case you get into trouble while inserting or pulling down or pushing it. So these are basic accessories which you require, and when you buy your rigid bronchoscopic instrument, it's extremely important to understand the kind of work and over a period of time have all of these accessories as part of your armamentarium to be able to help you perform procedures much better. This is everybody's dream. Everybody wants to insert a stent, but a stent insertion is itself a technique. So you have to fold a stent into a small applicator and be able to insert it. And the TON stent applicator actually helps you do that. So what basically the TON stent applicator helps you is to fold the stent over itself and load it into a tube. And when you push it outside, it just gets released. So that's basically what the TON stent applicator does. There are various companies which have come out with it, and this is the one by, the original one by TON, and this is the one which, Dr Dumon comes out with, but the mechanism is similar. All these instruments do just the same. Fold the stent on itself, load it into one small tube, and when you push it out, it just gets extruded and takes the shape that it's originally meant to be. Fancy instruments, if you have money and over a period of time the kind of work that you're doing, you can upgrade yourself to have something called as the Tatao forceps. Here you're actually seeing how Oki stent is being customized to have a right upper lobe opening to ventilate the right upper lobe. And many people who are beginners who find it very difficult, I think Sachin dealt with how to size a stent very briefly in his talk. But this is a flexible aerosizer, very few people have it, but it's not absolutely necessary. Like Sachin actually detailed in his talk, you can go back, you can do a 3D reconstruction, sit with your radiologist, measure the anterior posterior diameters, or when you're doing your check bronchoscopies itself, you get an idea of an assessment of how to basically go about sizing the length and both the diameter for a stent. So this is the rigid aerosizer, while what I showed you in this slide was the flexible aerosizer. I don't think these are instruments available in the workshop, but we'll try and give you some idea of what it basically does and how things are in my next slides. Another stent, which is called as the Freitag stent. This is something which is very close to my heart because this is a stent which is probably the most physiological stent ever made. Is the kind of stent which is very difficult to deploy, and for that you require a special forceps, and of course then you have the jet ventilators, which can be your hand jet ventilators or it can be your jet ventilators which your hospital has. Preparation General anesthesia, oxygenate, clear pharyngeal secretions, open, take off and look for dentures, and if you want to decrease secretions, use glycopyrrolate. These positions I am sure we are going to take you through very, very slowly. I'd urge all of you to spend a lot more time during our hands-on session to understand the positions. Basically, you require to orient all the three axes in line. That's the oral axis, the pharyngeal axis, and the laryngeal axis, and you end up the patient in a sniffing position, and that's the best way to have your rigid bronchoscope inserted. It takes a bit of skill, but over a period of time you'll build up to it. Intubation, either you can do direct laryngoscopic or over the endotracheal tube. All you basically require to do is, many people who are budding interventionists have this big problem that they find it very, very difficult to intubate. There's no shame in asking your anesthetist who's beside you to intubate. He has a laryngoscope, he'll open it up and he'll put the rigid bronchoscope, and then you can do your procedure. Over a period of time, you can pick up that skill. There are various steps. These steps are going to be dealt with during the procedure, during the workshop, so I'm not going to go into the details of it, and I'll also skip the intubation video. This is how finally it looks when you've intubated the patient. And like I said, if you're having a problem, please ask your anesthetist, they'll probably help you with the intubation. And this is an important slide, I'm going to spend 1 minute with it. There's a tumor actually you can see out here, just above the carina. And this is your rigid bronchoscope. So what you basically do is, when you have inserted your scope, you measure the distance from the incisor teeth to one of the landmarks on your scope and measure the distance. This is the end of the, so this is where your carina is, there's 14 centimeters. When you pull it to the lower end of the tumor, it is 17. Okay, so it's 3 centimeters above the carina. You come to the proximal end of the tumor, it's 19 centimeters, so your tumor is basically 2 centimeters. And then what happens is, you come near the vocal cord, it's 25 centimeters. So these lengths basically help you decide what is the length of the tumor, and also will help you decide on what kind or what length of stent is really required. So with that, I'll probably call it a day for the talk, because I think there's a lot of concepts that you guys need to understand during the workshop, which I'll probably take you through. So that's really about it. Thank you, ladies and gentlemen. Happy to answer any questions that you have, and go back to the slides if you have any questions. So
thank you, Dr. Kedar.
Thank you, Dr.
Presentation. I think we gave you very less time. I think it deserves one more presentation over there. So anyway, any questions from the audience? It was a wonderful presentation, and there's a basic, regarding instruments. Yeah, please, go ahead. Anybody has questions?
So people who are doing rigid bronchoscopy can't ask questions, isn't it?
Now you have, see, our ears, we are losing, so they deserve to ask questions.
Go ahead. Go ahead. What is my experience of a biodegradable stent? So this is an advanced question. I'll just deal with it because I have prior experience with having seen biodegradable stents. Now, what is important to understand is, with the evolution of not just the rigid bronchoscopy, with the advancement in material science, biodegradability is a property which we want to exploit in the next generation of stents. And there are three things that we are looking at. We are looking at one, something called as the drug elution, especially in patients with cancer where you want locally drugs to be released. The second property, like you've asked this question, is biodegradability. The third property we want to exploit really is customizing a stent to a patient's needs. So the next generation of stent is likely to be something which is drug eluting, biodegradable, and 3D printed. At this point in time, we are not there yet. But Tinku has just recently published in few WhatsApp groups and probably on Facebook his personal experience on inserting a biodegradable stent. I'm not aware about which company it is. What I have seen personally in my practice during my training is the fact that the biodegradable stent is an ELA stent that is made in, I think, Slovenia or something like that, and it's a gastric stent, and that can be inserted in the lung. But the biggest problems have actually been during the degradation process, the particles that ooze out. So patients tend to cough out particles of the stent when it undergoes the degradation process over 3 to 6 months. So the biggest indication for this has been multi-level tracheal stenosis or vaginous granulomatosis, where these stents have been tried, especially in Germany, which is where I have done my training and I know it about. But it's just a proof of concept at this point in time, and whether they can be routinely inserted is something that we'll have to wait and watch. As far as Tinku's case is concerned, I'm not aware about it, what stent he has put, but maybe he's going to be in the conference today or tomorrow, then maybe people can ask the same question and we should have more details about it.
Doctor, Kedar, it was a very good
Yes.
talk. Just for the sake of the beginners who start off with rigid bronchoscopic intubation.
Yes.
So, what size of the barrel you minimally choose for a patient who is an adult Indian male and an adult Indian female? Because that is when you get really confused. You start intubating and then you realize probably you chose a wrong barrel size. So, what would be your experience on that?
So, there are two ways to answer this question. One way to answer this question is what is available. The other way to answer is what is your practice. What I've generally noticed is if you go to the West, or rather what is available is size 12 and 14 tracheoscopes. That's something that is very, very clear. And I have found in the Indian population starting with the 12 works because we are not as huge as the Western population. So I don't usually tend to start with 14. But if it's a male, slightly hugely built, 14 is something that can comfortably go. But in my experience, if it's a lady and you have to insert a rigid bronchoscope in her, almost always I've always used the 12 and have been really comfortable with it. I've never used a 14 in a lady, at least in the Indian circumstances. What is your experience?
Yeah, I think like the audience should be more interactive because these are planned in such a way that where you bring up with your own doubts and get it cleared. So I'm asking on behalf of you, like in my experience, we generally start off with 13 for an adult Indian male. But there are few patients, for example, patients who are very thin built, and you will feel like once you are negotiating the vocal cord, there are chances that you will injure with a bigger barrel. So what we do is we try to start off with 13, but in case if you feel like we are not able to intubate them properly, then we go back to 12. For almost all adult Indian female, we start off with 12. That has been our practice. Except for people who are very good built, then we still go for 13. This is very important because choosing your barrel size plays a very important role, especially when you are doing a stenting process. Because there you need to put the stent, along with it you need some access for vision. So when you are attempting any sort of these stenting maneuvers, then bigger the diameter is always the better because you have an access for vision as well as for deploying your stent. So we always choose 13, and there are instances when we had to put a Y stent, we had even gone to 14 size, which was available in the Novatec. And another question which I as a beginner, when we all started doing it, was how are we going to ventilate these patients? Because this is a very practical question. Because most of the cases, when you start off your IP, what you see is the anesthetist is also starting his IP along with you. He has never done a procedure of rigid bronchoscopy before. So you need to be very careful in taking your anesthetist along, and it is your job to make sure that the anesthetist learns while you are learning the IP as well. So what has been your experience? There are a lot of literature about jet ventilation being the mode of ventilation we use for rigid bronchoscopy. But till now we have never used jet ventilation in our practice. Like we always go to routine modes of inhalational anesthetist along with IV sedatives. So what has been the protocol at your center?
So initially when we started our procedures, we were going ahead with our routine ventilation, and we did have some problems initially in terms of having hypoxia being prolonged during those times. Luckily for us, because we also had a lung transplant program alongside, we were able to indent a jet ventilator. So we've got a jet ventilator, and for us it's been really smooth. I personally believe a jet ventilator helps, and for those people who find the initial cost of a jet ventilator very high to invest, I think there's something called as a manojet, which is actually a hand jet ventilator. It's a little labor intensive for the anesthetist, but over a period of time your anesthetist colleagues tend to become much more comfortable with its use, and I think is probably an instrument of choice for the Indian setting. This is what I would really suggest. But can you still go ahead and do rigid bronchoscopy procedures with conventional ventilation? Yes, it can be done. But yes, like what Vishweshwaran has said, you have to take alongside your anesthetist with you, because at the end of the day, please remember that it's a shared airway. It's as much a pain to lose a patient for you as much as it is for the anesthetist. So unless you communicate, you decide, you have a timeout about discussing what plans you have for your rigid bronchoscopy, things will start to become more difficult and troublesome over a period of time.
Just one word on here, Prince here.
Sorry.
Jet ventilation, I agree with you. A few words on the complication of jet ventilation. What I understand, when Dumon put a website and this experience, he categorically read no jet ventilation, rigid bronchoscopy. We have moved, I totally agree with you. So a few words on that contradicting statement.
So I'm not aware about what Dumon has put on his website, but I did my training, a lot of my rigid bronchoscopic training in Germany, and I always ended up seeing them use a jet ventilator. So they used to have an older series of jet ventilator called the Mistral, which is a very small device which takes you through the entire procedure. And since most of the German anesthetists use TIVA, here we still have to convince them not to use inhalational agents. I find it a little difficult to interact with our anesthetists as well. But like Vishweshwaran has said, it's always your team building, your discussion with them that carries forward. As far as complications are concerned, there are periods of hypoxia during our procedures as well, and we've had our own set of complications because of that. To my mind, it's barotrauma which is your biggest problem, but with over a period of time, the anesthesia, understanding the workings of the jet ventilator, usually that gets taken care of. And we've never had a pneumothorax.
No.
We've never had a pneumothorax.
And what was that trick that not having pneumothorax?
So,
pneumothorax is the main complication of the jet.
So,
you are inside and this other person is ventilating. You are concentrating on your screen. You have no idea what is going on in anesthetist's hand. And suddenly you realize hypoxia is intervening, and then we are running around.
So, well, I've never had it. Okay. So as far as trick is concerned, I don't really know of any trick, but they do have the trick in some ways is probably to increase your number of jets while keeping the volume. That's what I would call it a trick, but I almost always have never a say in it because I'm concentrating on the procedure and I leave it to the anesthetist.
You have a wonderful setup.
Yes.
So what we experienced, the pneumothorax happens. What happens is we realize that their catheter, we want to put the catheter inside in your barrel. That is one thing that will take the space of your barrel, which ideally we should not allow because our barrel has our own instruments. There is hardly space over there and at 13 mm scope. The other thing is when you are concentrating on a tumor and doing it, this catheter which is down, if it stays in the trachea, it's fine. But when the anesthetists there, the juniors there, they keep changing. You are not noticing what is happening at the end. They keep changing. This catheter slides down to the main bronchus. That's a recipe for pneumothorax. Now he has entered in the main bronchus. He is pushing air. At the same time, you did something on your tumor and little bit hypoxia. He pushes more. Reverse is happening. He is pushing more. The pneumo is happening. He is thinking the ventilation is happening. He pushes more pneumothorax, and it will end up in the bigger pneumothorax. So I think if they are doing jet, have an anesthetist like Dr. Kedar who is so experienced and keeps the catheter in the trachea. Otherwise, you make sure that it is always in division. He should not be allowed to put the catheter into the main bronchus. If the anesthetist here,
so what happens? Just to interrupt you, we don't keep it in the trachea. So you have a jet, attachment that comes with the rigid bronchoscopy.
Wonderful.
And
so
we almost always end up as an open ventilation.
Correct.
So it's never you don't close any of the ports because that increases your chance of barotrauma.
Your rigid has this port and your jet is going through that.
Through it.
Right. If that is the way your anesthetists is doing, that's the best way to do it.
Yeah.
Just a couple of comments on
yes.
the jet ventilator. As you mentioned, the manual jet ventilator costs just around 1.5 lakhs.
1.5 lakhs, yes.
For beginners, probably they can start with the manual jet ventilator. For the last 1.5 years, we've been using jet ventilator because our anesthetist is not at all comfortable with the normal conventional ventilation. We have used it for around 15 cases or so. We didn't have any pneumothorax. As Kedar said, we attach it to the proximal end of the rigid bronchoscope. The adapter which we use for the IV cannula can be used to attach the jet ventilator to this proximal adapter.
So the Manujet comes with the attachments. You don't really have to have an extra attachment. So there is an attachment which goes into the rigid bronchoscope's jet ventilator attachment. So you don't need anything extra beyond.
I don't remember what company our jet ventilator is, but we keep it attaching. Probably we lost actually. There's a small,
very small attachment.
Attachment which comes. And the second thing is regarding the prism action. Regarding the jet ventilator, we also didn't encounter pneumothorax actually. That should probably, because there was a pressure release mechanism. Sometimes we keep the proximal end of the bronchoscope.
You almost always keep it open. We never close it.
We keep it open. So there's always a pressure to come back. We don't allow the pressure to build in. So we never had any like barotrauma in the last 1.5 years. So in the pre-COVID period, because this almost that time we started using the jet ventilator. And regarding the prism actually, so most companies do not come with prism now. So do you think there is a real need of prism in this? We don't.
I'm a very strong believer in the prism mechanism only for the fact that in an emergency situation, when you want to intubate, you do not always require an optic. All you can do is go the old standard way, have a prism which illuminates your distal end and look through the rigid bronchoscope directly to intubate the patient. In a real emergency, that's a boon. In fact, when I trained, my chief actually told me that if you can intubate a patient without using a Hopkins, you actually have the rigid skills. So that's like the next level of having a rigid skill. So if you ask me, I would say that all interventional pulmonologists should be able to intubate without having a Hopkins. But that is not necessarily a mandatory requirement. However, if you have something like Dr or F Dumon, the question doesn't arise. If you have a rigid bronchoscope or stars, which is what we had, which is because my thoracic surgeons had ordered it 5 years before I joined the institute, I got it as a legacy. And incidentally, I got trained on the same, so I'm quite happy with the stars one. But like I said, with the advancements, we have more ergonomy, and today we have much better features in both the Data Novatech and in the new series of F Dumon. So I think there is an advantage, but I think each of us has to look at the cost versus benefit, the return on investment, which is now the buzzword in many of the hospitals, like the cost of F Dumon and Data probably should also justify the returns that the kind of cases that
even if you use a prism, you attach a light source.
Yeah, it just goes onto your rigid bronchoscope. You don't even need a Hopkins. So once you have inserted that, all you require is a flexible for doing the rest of the procedure.
But we always use only the Hopkins.
Yes, you always need a Hopkins.
Exactly. So, wonderful discussion. I want to thank everybody who asked questions. We are running out of the time. I think we crossed it. But
yeah, you can ask the questions in the workshop. I think, if the chairs would allow it, I don't think we should go ahead. Thank you so much.
Kedar, so much. Just one question, last question.
It was an amazing presentation, but if a person wants to start a rigid bronchoscopy suite, you have shown the collage of instruments. Could you just tell us that what are the basic stuff that a person needs to have in terms of tracheal scopes, the bronchial scopes, the telescope and everything?
So you go to any one of the companies that currently market the rigid bronchoscope, they'll give you a basic set. With that, you of course obviously require optic, which is your Hopkins. With that, of course, comes the monitors and the light source. This is really basic, and this will only help you intubate. My suggestion for beginners is start out with doing things like tracheal stenosis dilatations. So for that, you require at least one therapy, which is either hot or cold. Cold is a little more costly these days. Hot is already available in most of the hospitals. All you require to buy is your accessories. The hot comes with a snare, a blunt cautery probe, and what are the other instruments? Blunt cautery probe and snare and knife. Yes, knife. So all you require to do is have these three instruments. So if you have these three, any electrocautery instrument that's already in your hospital will be possible for you to do the procedure. So start out with that and have balloons. So once you started doing few post-intubation tracheal stenosis dilatations, you're confident about your skill, then start upgrading to looking at something like extrinsic compressions. That's like the next level. Because all you require to do is insert stents out there or just do some kind of dilatation. Or use these in cases like hemoptysis, or there is a mucosal bleed where you want to stop it. Or start using it for transbronchial cryobiopsies, because you put in your rigid, have one balloon which could be your Fogarty, and just take biopsies. So once you build up to this second level is when you start thinking about stenting and coring and going to the next level, which is when you start to have an absolute indication that you need a cryo, you need a hot therapy, you need your APCs and so on. So I feel that you should build up your interventional practice over a period of time with the complexity increasing in a graded manner. If you've been through a training program like mine, of course you can have everything, but I think as beginners, start out slow, have patience and build up on your equipment and your skill. This is really what I would say.
Kedar, with this we'll close the session.
Thank you.